When I was young, a long time ago, sometimes at the end of Bronze Age, my mother told me that the roads to hell are paved with good intentions. And part of what I've heard today is a lot of good intentions. I love it, it's great, good thinking and everything. But if we reduce the prom ritual to only ask the patient and not put in place the mechanisms by which we drive the change in healthcare, we have done nothing. A lot of hot air. Which means that the question we got from over here, somewhere at the end of the last session, how do we do it in practice? Happens to be the best question of the day. It's absolutely the best question of the day. Because we used to rig healthcare from the head of the professional that saw the patient from day 1 to day 20, did the diagnosis, did the treatment, and said, now you're feeling fine, go home. But today, healthcare is not a long admission with a direct relation with the patient. First of all, chronic disorders are everywhere. Secondly, any disorder you have will create at least 10 different contacts with healthcare. Which means that your idea of what's good for the patient may not be the same as your idea as what is good for the patients. And hence we end up in a situation that one of my patients told me some years ago. I go around, I shop around, I try to get good advice, and everywhere I go they tell me, who are you and why are you here? That's not exactly the professional roles that the professionals want to keep. OECD have stated that Sweden has the best healthcare in the world within units, but we suck between units. Means that we lose the patient loses all care context once they leave the primary unit. Some years ago, I was fortunate enough to be part of the ITROM initiative, International Consortium for Healthcare Outcome Measurements, with the idea that if we're going to send out 300 people and ask patients what they feel about healthcare, we might as well do it in an organized fashion. We have to remember that civilization, the way we see it, schooling, education, university, retirement, and work life, everything we have as a society is based on organized knowledge, not just data, organized knowledge. In order to get organized knowledge out of prompts, we have to collect them in an organized fashion. This was a starting point on my side. 25 to 30 years battle over what type of psychotherapy should we administer to patients with anxiety and depression. The nice guided initiatives that ended up in the increased access to psychological treatment paradigm in England that now several million patients have been through, where they ask the patient every single session, how was the session, how did it go, what's your experience? Every single session. Turned out they solved in 3 years the discussion on is it going to be CBT or is it going to be psychoanalysis? End of discussion, the patient ruled. So they in 3 years, they built the collective experience to influence the way the whole health industry worked within that area. It's a magnificent experience. Another experience that also led me to be engaged in this question was the the very fine operation results in prostate cancer that we had in Sweden. Lots of survivors. The doctors were happy. And we then looked at the Martini clinic in Germany. They had the same type of survival rate. And we said, well, we're as good as the Germans, so we were really happy. The thing is, in Germany, they also asked the patient, what matters? Well, it matters to be nice to my wife now and then, and it matters to be able to not to hold my urine so it doesn't leak everywhere. So I don't want to be incontinent, and I want to have a remaining as good sexual function as possible. Good, reasonable request. Turned out, they had, like numbers like 5 and 8% of failures in those two, in Germany. In Sweden, we forgot to ask the patients. And when we started, we found, after a year, 70% sexual dysfunction, 50% incontinence. And in just some years, just by asking the patient, we got the drive for a change also of the surgical behavior, meaning nerve-sparing surgery, very close workup, including post-operation training, etc. The influence of the patient data on healthcare, that's what matters, because that in turn will serve all the other patients that come in. Evidence-based practice demands practice-based evidence. You guys are the ones that are going to do that. And WHO says if we don't organize healthcare in a professional way, it's not going to work. So we're in trouble. Chronic diseases, 75% of everything we do. So we need to follow these guys, empower them, and see to that they get the best health experience with as few contacts as possible with healthcare. That makes them happy, makes us efficient, and everybody's happy. So in order to sort of understand why the drive for Prom comes from, one of the theoretical frameworks is value-based healthcare. We used to drive healthcare's content in the head of the doctors. And the healthcare services by nice people that did nice things when they happen to meet the patient. Not the good service industry. Not good quality. So by constantly and systematically measuring health outcome and looking at how much did it take to get there, it's possible to align the interest of the patient to get better, the payer to pay as little as possible, the profession to do as good as possible for the patient, and have them happy. Because the problem that we've had for the last 25 years is that we haven't aligned those. So the economists have been in one corner saying, save 5% per year. The doctors have said, well, in the interest of the patient, I want to do a technologically very, very advanced thing. And the patient has said, I just want to be met and be taken serious and be listened to. So we've had three different logics that have influenced the way we organize healthcare. And by just putting up this very advanced differential equation, it's very easy to see how we can align these. Paying for the right thing means that if you only reimburse what's done in the hospital, it's very easy to be a reimbursement. The problem is that you drive volume. And if you want to pay for prevention, you've got to find out whether that prevention is effective or not. We don't have that number. We know how much money leaves the taxpayer, but we don't know the use of that money. So we try to push everything over here. And the only way we can do that is to get data in order to go in that direction. And that's part of the ITROM initiative, to really see what does the data deliver, what does decision making, what is it based on, and how can we also align prevention into primary and secondary prevention into healthcare. And build it into a logic that says that local quality, measuring Proms, should be done the same way you do it for national quality registers and the same way you do for international comparisons. There's no reason to measure it in a different way. If we can agree professionally to do it on the international level, it should as well be possible to include that in the local measurements. So we have tried that quite extensively, and we always end up, it's not trivial how you deal with the data. And the reason is that a lot of people say, big data, and I say, trouble. the reason is that if we have a source like this, we can get practically from any type of data, we can get a database, which is pseudo-clean. And that database will provide us with some system predictions. You know, intelligent stuff like if you're poor, you get poorer quality of healthcare and stuff like that. Things that we know essentially. The problem is we do not attain individual level predictions. So we can't use these types of big data approaches to anything but sort of systems level decisions. We can't use them for patient level decisions. DIGO still rules. Garbage in, garbage out. And why are we in this dire strait? Well, it all started with a doctor doing the individual patient record. Essentially an analog type writing down what happened. And then the computer came, so then we put the binder in the computer. So we had this one, the non-searchable sort of e-data thing. And we have that. I don't know if you've seen that sketch. Computer says no. Has anybody seen that? That was the age of computer says no. Nowadays we have databases, and we can say that I have you in my database. I don't know where you are, but you're in my database. And that means that I can search within the database reasonably well, get it reasonably well. The problem is it's not enough, because I cannot compare between databases. I end up, there are very few databases with competence to go between databases. And the next level is where we need to go in order to get rid of the straitjacket from the computer guys that look upon us as lesser knowing. And that's what we call semantic interoperability, and I'll get back to that. Because if you have, I'll do it here so that everybody sees, if you have different EMRs, electronic medical records, you put them in a computer and you get the computer to talk to one another. That doesn't help. Even if you use almost the same sort of programs that can talk to one another, that doesn't help. Unless you have a full mapping of the language between the two. Otherwise, it's going to be two-year-olds discussing Goethe and Faust. Blah, 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 blah. It's not going to be a lot of data coming through there. It's not until we have got the connection between the language of the computers and the language of the process that we run in healthcare, what's called process interoperability. It's not until we join those two that we can get a proper feedback loop improving healthcare. We're working on that in order to get sort of I'll tell you more about iChum in a second, but we're working to get the language correct to begin with. And that's my take-home message number one. When you now start a national Prom initiative, get this semantic interoperability straight to begin with. You're going to be leaders of the world if you do it. It's a lot of work, but I tell you, it's worth it. And it can be exported directly if you do it right. See, how do I get rid of that one? Go away. Patients are always right. That's why you should do proms. And I love this paper. It's some years now. It's from 2004. It's the doctor asked. We asked the doctor after the patient visit, how was the patient? And we got the rating 0 to 10. And then we asked the patient, how are you? Rating 0 to 10. And then we measured cytokines, you know, male cold poison that makes men go like that from a cold. It's an inflammatory response. And we figured out that the inflammatory level, a level of IL-6, correlated with how the patient said they felt. No correlation whatsoever with what the doctor said. I love that. It's a great paper demonstrating that patients know their physiology. No, that's too difficult. Our whole idea is that the patient owns their information. They own their information. Within this year, all patients in Sweden will be able to see their own health records. Everything. We also want the data to be directly included in the electronic medical record. Get the Prom data back. We have now 90% of people in Sweden have these terminals in their pocket. And all of them go to the bank, and since they go to the bank, they have an ID, and since they have an ID, we have point-to-point security, and they're able to report back right straight into the electronic medical record. That's cool, because that means that they also can directly report to the quality registers. The patient must be able to withdraw their data if they want to. And they can do that, provided you make your computer systems correct. And we tell our people, and it's very easy to tell them, the patient data is a wonderful resource. It's not trouble, it's not work, it's a resource for knowledge. And we should always view prompts as a delivered service from the patient that needs a receipt. Not taking care of the data means essentially piss off. And that's not something we want to tell our patients. So our strategy is that we close the loops. With the patient in the middle, we can get information from electronic sources, from the doctor, and from the healthcare system. And all of them should be aligned by the same type of quality systems. That's too difficult. Well, this one is less difficult. This is just to remember that closing the loop of plan what you're going to do what you're going to do, check if it worked, and then change your whole idea of how it works. You have to build that into healthcare in order to get people to do the right thing. And you have to know what interests actually try to influence your arena. Quality people, research people, ethics people, economy people, etc. Wrong. That one. So what we have built, we have now built a system where we look at the data on the bottom. I should be here because it's 3 screens. I'm sorry. It's just that it's more fun to jump around. Where all the data come in the bottom, that becomes an observation that either is guided by a form or by the lexicon. That's all it is. So we have a full structured term that enters into the health record. That's assigned context, and with that context, you can build up a decision-making process, which is what we call a clinical model. By doing it that way, we can know exactly where in the process did that Prom actually deliver the data. And by doing it that way, we can sort of secure the quality in each step of the way when the patient goes through healthcare. That's too difficult. So we started ICHON. And the idea was that it has to be done in a proper way if we want to get it correct. People in healthcare are getting crazy because it's only the economy that rules. So if we align the professional interest together with the patients, then we're stronger than the economists. It turned out the economists said that if we align with the patients, we're stronger than the profession. So now they're all aligned in this. So the idea was to get international comparisons to drive change. And in America, between commercial systems, quality measures to drive change. And I already told you that sort of both the payers and the providers, both the hospitals and the insurance companies, all of them love this one. The problem we had was, of course, that there was no data. They were not standardized, and they were not patient-focused. They were much more process-focused. How long did you wait in the waiting room? Well, who cares 3 years from now? I want to know if I live and can walk around. So we ended up collecting or inviting a number of professionals groups that were taught the way you should analyze this, and above all, the ending of how do you measure an outcome as compared to a process. And measuring the outcome is really where you need to ask the patient in most of the cases. And we had, of course, patients joined all of these professional groups as reference. And there's also a theoretical split in what the prompts represent. They represent tier 1, you know, if you survive, etc. And what was the road to recover, and how sustainable was that recovery? So you can sort of sort that out. And there is also a fourth tier that's important, and that is when you ask a patient something, you also put an idea in that friend's head. Meaning that if you ask in the wrong context, you may influence the trajectory. So what is an outcome standard set according to IHO? It should be, you shouldn't measure everything just because you can measure everything. You should measure what's important. So, and try to measure as little as possible. It's expensive to measure things. So we derive 10 to 15 outcomes per diagnosis, have good definitions, and always look on the literature exactly so that it's done the same way. And it's developed in these professional groups internationally, and we fly them by different patient advocacy groups and governments and payers, etc., in order to secure them. And this one. So now the first few years we have done these diagnoses, and we're doing 9 more. In 2016 we're doing those. So this is a lot of people that are volunteering their time to publish these open publication, openly available data sets that anybody can use free of charge, which is great. And we are now starting the work to get everything coded in an open semantic standard. But that work is a lot of work, and it's not really finished yet. And what we do is we have a very, very sort of structured process to get through this. It takes 7 months to run a group with 25 people across the world to go through this. And as you can see, Denmark has been part of one group, and we have been busy boys because I kicked around me, both me and Stefan kicked around. So it's a lot of international spread, and we're looking both at high-income country, medium and low-income country problems. And a lot of organizations have joined, paying a little sum just to sort of maintain the train And yesterday I got the word that even the Karolinska Hospital in Stockholm have joined, which is nice. And does it matter? Does it make a difference? Yes, it makes a difference. We have seen openness coming up in the US, being previously data has been very close to the doctors. And so we have seen a transparency move coming out of this work. And let's see, how many minutes do I have? I have some 15 or 10? 15? 15, okay. I'll be I'll be nice. We have launched now a program, as I said, local level, national level, international level, with the same data structure all the way through. And we launched that program in the Stockholm County. It's 2 million people, and we launched it in 4 diagnoses. That's the 4D project. And the idea is that by improving the data access on that access, we will be able to deliver a higher quality to the patients and have greater patient engagement in the process. So the idea is simple, that we analyze the patient trajectory through the healthcare system. And we save the data on the way, both health data and research data in the same type of databases. And we see too that the data is so structured that we can go back with the knowledge to the process all the way around. And we do it systematically, and we want to be able to build knowledge along the way, and I'll give you some examples. So we've looked into arthritis, breast cancer, diabetes type 2, and heart failure. Heart failure had a staggering social gradient. So if you were poor, you got much worse care than if you were rich. Diabetes type 2 was very, very different in the northern and southern Stockholm. Breast cancer was, let me put it this way, had some quality struggles. And arthritis was the top star, the gem in the crown. So that one was used as a role model for the others. And we looked at lateral spread of knowledge. And for each of these programs we've done a number of things, but we also done jointly some solutions in informatics, allowing the patients to take their own blood samples. Allowing patients to online screen, guided screening for their own disorders, and to help them help healthcare to make the correct decisions, collect data for research, and also informed consent management to participate in clinical studies. A fantastic opportunity. So the online screening means that we have now decreased the time from the first contact to healthcare to diagnosis in arthritis with 4 months, which means that we have reduced joint destruction with 4 months in the acute phase. Quite dramatic, just by using a simple e-tool. Online screening, they just fill in, and the healthcare calls up, or they're just asked to call healthcare. A simple tool, ask the patient, self-diagnose, and sort it out if there is trouble. Having a chronic disorder means that I go once a year to the doctor, see the doctor for 3 minutes and say everything is fine, and I go home. Expensive, meaningless, and very frustrating. Instead, you're giving empowerment to have your self-referral to take a blood sample whenever you feel down, if you have a proper biomarker for that diagnosis, guiding you together with healthcare whether you should go back and forth. And all that is done over the phone. You just fill in, I want to do the blood sample, and then you get all the labs in your neighborhood, and then you can just go there and you get the answer yourself at the same time the healthcare does. Informed consent, moving from some 60% consent for biobanking in breast cancer to 97% in just half a year for the whole district, which means that we now have the richest and best biobank for personalized medicine research in the world. Very quickly, very rapidly, and all the sisters want to help the other sisters, and they're just offered that opportunity here. We've set up the data network in order to have it structured in a way so it can be useful. And applying the value-based healthcare theories on this means that we've been able to get a very structured patient data together with very structured healthcare data, meaning that we have been able to reduce the writing and dictation in the healthcare records with some 80%. Because we've gone back and just say, I just want the structured data. If there's other data, I'll take that too, but it's very, very rarely is, because we know the process exactly when we deal with these types of disorders. Which means that we have improved service, improved comparability between patients, and also the ability to directly from the patient put data back into the health record. So by this we have been able to make everybody happy, the patient and the relatives, the healthcare providers, the clinical researchers that now can have they use the same railroad to collect the data as the clinic does. We don't have to build up RCT frameworks. 60% of what it costs to make a drug study is building the infrastructure to do it. Here we just have it. So, the take-home messages about all this is, unless we make concerted efforts, and that means doing the same thing, to handle the information delivery, healthcare system will not thrive. We will not get people to change behavior unless we go back with the data to healthcare in a way they can understand it. That means what? It means reduction, reduction, reduction of numbers, and making it from data to information, from information to knowledge. It's knowledge that we need to build, and if we want to build that, we have to be extremely systematic and have continuous data collection where both the patient data and the care data is collected together. So coming with a Prom form and asking a patient to fill it in, to me, is an extremely big responsibility. The responsibility is not getting the data from the patient. The responsibility is being so systematic that that data, that effort from the patient is countered with a real push for change of healthcare. Take home 2. Only a proper feedback to healthcare with both quality and economical data will drive the necessary change. The professional logic is to go for more and more technology. The professional knowledge is to have the patient wait in the waiting room, then just see them quickly and throw them out. The professional logic in the old system is that I know best. And and we know that we have done very good psychological studies demonstrating that if the patient case goes well, it's thanks to my professional standing. And if it doesn't go well, you know, it's unlucky and very difficult patient, etc. So you externalize that, which means that single observation from single person is a lousy source of data. We need to have systematic, system-oriented data collection in a proper way that really helps us. Quality and process data is a strategic resource in healthcare that should be owned by the healthcare provider. The healthcare must own their own data. There is no excuse for the hospital owners and healthcare system owners that allow their data to go into the cloud of consultants. That means that they send away their most important source for improvement, namely strategic data. And especially if the patients have given their trust to the organization to give them their own raw data, that shouldn't be sold off to somebody else. That must be owned by healthcare itself. I used to have a computer that said 100% Microsoft free, but I now want a healthcare system that says 100% consultant free. And I say that jokingly, but I really mean it. I really mean it. We have to close this semantic interoperability gap very clearly ourselves. We have to do it in a way that we can close the knowledge loop, the PDCA loop, the knowledge loop from getting the data, understanding the data, changing the process. And in order to have that happen, we really have to own that data and have the data in our own hand. So thank you very much.